Welcome back to the deep dive. Today, we're doing something a little bit different, which should be really useful. We're diving into a set of revision notes that you, our listener, actually shared with us. The topic, subdural haematoma.
That's right. So you've put in the hard work, pulled together the key facts from your sources, and our job today is to, well, go through those notes with you. We'll try to pull out the really high-yield stuff, the most important bits, and turn it into a clear guide. Perfect if you're revising or, just want to get up to speed quickly on a pretty critical topic.
Yeah, absolutely. Subdural haematoma, it's one of those things that crops up sometimes when you least expect it, and knowing it well is just essential. So, okay, let's dive in. What exactly is a subdural hematoma? Let's start right there.
Okay, so at its very core, it's simple. It's blood collecting where it shouldn't be. But the key, the absolute key, is where that collection is.
Right.
It's specifically in the subdural space.
Right.
That's the space between two of the protective layers around the brain, the meninges.
Okay, the meninges. So your notes lay them out. You've got the tough outer duromater, then the sort of web-like arachnoid mater, and then the really delicate pia mater sitting right on the brain surface. And there are spaces between these.
Exactly. The notes mention the key ones.
Yeah.
The epidural space, which is sort of a potential space between the skull and the dura. That's where epidural bleeds happen. Then our focus, the subdural space between the dura and the arachnoid. And then deeper in, the subarachnoid space between the arachnoid and pia, where you might see bleeding from, say, an aneurysm rupture.
Got it. So SDH is right under the dura. And what usually causes bleeding there specifically?
Well, the main culprits, as your notes rightly point out, are these things called bridging veins. They're small veins that cross that subdural space. They connect the surface of the brain to the big venous sinuses in the dura.
Okay.
So if the brain suddenly moves inside the skull, think about a sudden stop or a blow to the head, that kind of rapid acceleration or deceleration, those little bridging veins can get stretched, and because they're quite delicate, they can tear.
Ah, okay. So it's the brain moving and ripping those veins. Got it. Now, your notes also make a really important point about timing classifying them.
Yes, that's crucial. Absolutely crucial for how they present and how we manage them. They're generally classified based on how old the bleed is, acute, subacute, or chronic. And the notes are spot on. A significant SDH, whichever type it is a medical emergency. Needs fast action.
Let's really pin down that difference between acute and chronic. Seems like a fundamental split based on your notes.
It absolutely is. Acute subdural hematomas, they're collections of fresh blood. They usually happen after pretty significant trauma, serious falls, car crashes, assaults, that kind of thing. Often there are other brain injuries alongside it.
And how do they present?
Symptoms can come on fast. Sometimes the person goes straight into a coma. But, and this is a really key point from your notes, they can also have that so-called lucid interval.
Ah, yes, where they seem okay for a bit after the injury and then deteriorate rapidly. That's such a classic head injury concept.
Exactly. It's why you can't be falsely reassured just because someone seems okay initially after a bad knock.
Yeah.
Vigilance is key. On a CT scan, these acute bleeds look high-density, bright white, and they have this characteristic crescent shape, sort of following the curve of the brain.
Okay.
And because the blood volume can be large and builds up quickly, it often causes significant pressure, pushing the brain across what we call midline shift.
Right. Big trauma, fresh blood, fast onset, bright crescent on CT, potentially life-threatening very quickly. Okay, so what about chronic SDH? How does that differ?
Chronic is, a totally different beast in terms of the timeline. Here, the blood collects slowly, over weeks or even months. It often happens after much more minor trauma, sometimes so minor the person doesn't even remember it. Or it can even seem spontaneous.
Really?
Yeah, especially common in the elderly or people with chronic alcoholism. It's often due to the tearing of smaller bridging veins.
And the symptoms reflect that slower pace.
They do. They're typically gradual, progressive. We're talking weeks of maybe worsening confusion, headaches that just don't go away or get worse, maybe some drowsiness or fluctuating consciousness, new weakness down one side, speech problems, personality changes. It can be quite subtle initially.
So a persistent headache or gradual confusion in someone who's maybe elderly or has other risk factors that should ring alarm bells for chronic SDH.
Absolutely. High index of suspicion needed there. On the CT, because the blood is older, it started to break down, so it looks hypodense, darker than the brain, but still often has that crescent shape.
Okay, so minor bump, maybe none were called, slow onset over weeks, dark crescent on CT, often in older or more vulnerable folks. That contrast is really clear, and I guess the management approach differs too.
Big time. Acute symptomatic ones often need emergency surgery, a craniotomy to get the clot out. Chronic ones, well, if they're small and not causing symptoms, maybe just observation. But if they're larger or symptomatic, they're often drained surgically, but usually with less invasive methods like burr holes.
That really sets the scene. Okay, let's dig into the why, the causes and those key risk factors your notes highlight.
So the number one cause, as we've kind of touched on, is trauma. Anything causing that sudden head movement falls are huge, especially in the elderly, vehicle accidents, assaults, that brain shifting, tearing the veins.
But your notes say it's not always trauma.
Correct. Less common, but definitely important, are non-traumatic causes. Things like spontaneous bleeds, maybe from a ruptured vessel other than a bridging vein, underlying bleeding disorders, or, and this is a really big one highlighted in your notes, being on anticoagulant medication, blood thinners.
Right, which brings us neatly to the high-risk groups you've listed. Who are we most concerned about?
Your notes nail the main ones. Advanced age is a biggie. Chronic alcohol abuse, being on anticoagulants or antiplatelet drugs, warfarin, DOACs, even aspirin counts, and having any kind of coagulopathy, a bleeding disorder.
And your notes explain why these groups are more vulnerable. Let's unpack that. Infants, for instance.
Yeah, infants, especially under 1-year-old, and particularly in those first 6 months, it's a peak time. Their bridging veins are just really delicate. Now, your notes correctly mention that non-accidental injury, NAI, or shaken baby syndrome, has to be considered, and studies from the UK and Sweden highlight this link. But it's also crucial, as the notes say, to remember there are other causes too.
Right. And at the other end of life, the elderly. Why are they so prone, especially to the chronic type?
This is a really key concept from your notes. As we get older, our brains naturally shrink a bit, cerebral atrophy. This means there's more space between the brain surface and the dura, so those bridging veins get stretched tauter as they cross that widened subdural space.
Ah, okay.
Plus, the veins themselves can become a bit weaker with age. So even a fairly minor bump, one that wouldn't bother a younger person, can be enough to tear a vein in an older person. That's why chronic SDH is so much more common in people over 60.
That makes perfect sense. And alcoholism. Seems like it contributes in several ways.
It really does. Your notes cover this well. Chronic heavy drinking can lead to low platelet counts, thrombocytopenia, and make bleeding last longer. It also, sadly, increases the risk of falls and head injuries in general. And just like aging, long-term alcohol abuse can also cause brain atrophy, again, putting those bridging veins under more tension.
It's like a perfect storm of risk factors. And obviously, if someone's already on blood thinners...
Yeah, that's a major one, clearly stated in your notes. If you're on anticoagulants, any bleed that starts is likely to be worse because your blood doesn't clot properly. So a small tear can lead to a much larger hematoma.
So age, alcohol, anticoagulants, that's a really important triad to remember. Okay, let's revisit the mechanism, the pathophysiology. How does that blood collection actually cause the problems?
Right, so you've got this bleeding happening in the subdural space, usually from those bridging veins. Sometimes maybe a little cortical artery gets damaged too. Blood leaks out, it collects, and it forms a clot. Now, this clot is essentially a growing mass inside the skull.
And the skull's a fixed box, right?
Yeah.
There's no give.
Exactly. No room for expansion. So this expanding clot starts pushing on the brain tissue underneath it. That direct pressure, the compression, disrupts how that part of the brain works, leading to the neurological symptoms, the weakness, the confusion, whatever it might be.
Okay.
And your notes also mentioned that the hematoma can sometimes keep growing, maybe from slow rebleeding, or sometimes osmotic forces pull fluid into the clot, making it swell. This increases the volume even more, leading to a rise in the pressure inside the whole skull, the intracranial pressure, or ICP.
And raised ICP is the real danger zone. Can lead to herniation and serious damage.
Absolutely. That's the secondary injury mechanism that can be devastating.
This leads us nicely into a really crucial section in your notes, differential diagnosis. Why is thinking broadly so vital here?
Well, because the symptoms, especially for chronic SDH, the gradual confusion, the headache, the unsteadiness, they can look like so many other things, as your notes lay out. You absolutely have to think about SDH, especially in those risk groups. But you also can't afford to miss something else or wrongly blame, say, dementia when there's a treatable bleed.
So what are the immediate things you think of, the other neurosurgical emergencies?
Yeah, the notes list the main intracranial bleeds, epidural hematoma, different space, often arterial, different shape on CT, intracerebral hemorrhage, bleeding within the brain tissue itself, subarachnoid hemorrhage, often from aneurysms, and also a brain contusion, like a bruise on the brain.
But your notes have a much longer list too, including medical problems.
And that's such an important point they make. You need to consider things completely outside of bleeding, like could this be an evolving stroke? An infection like meningitis or encephalitis. Could it be a brain tumor? Maybe one that's bled into itself. What about metabolic issues causing confusion, like DKA or sepsis? Or maybe it's just someone with known dementia who's having a sudden worsening. Or other weird things like toxoplasmosis.
Wow, okay. It really drives home that gradual decline in an older person isn't just getting old, needs a proper look.
Definitely. And connecting back, your notes rightly flag again that in kids or the elderly, if you find an SDH, you do have to consider non-accidental injury as part of that differential.
A very important point. Okay, differentials covered. What about epidemiology? How common is this?
Your notes give good context. The incidence varies, but it definitely gets more common as people get older, particularly over 65. That fits with the atrophy and vein fragility we talked about.
Any specific figures mentioned?
Yeah, they mentioned that about a third of patients with a severe head injury end up developing an SDH. And the incidence clearly rises with age. Those studies you noted also highlight that infant peak 0-1 year, especially the first 6 months, often linked with NAI reports.
Oh.
Oh, and there's a mention of a rare cause spontaneous intracranial hypotension leading to SDH.
Low pressure causing a bleed. That's interesting. Okay, let's tie it all together clinically. How do these patients actually look when they present, and what are the key things to check on examination?
Okay, presentation really depends on that acute versus chronic split. Acute SDH usually follows a decent head injury, moderate to severe. The patient might be knocked out immediately, or they could have that lucid interval we mentioned seem okay for a bit, then crash as the pressure builds.
So, rule number 1, never underestimate a significant head injury, even if they look okay initially.
Couldn't agree more. Now, chronic SDH, that's the slow burner. Symptoms creep up over weeks, often 2 to 3 weeks, maybe longer, after an injury that could have been really minor, easily forgotten. Especially in the elderly, alcoholics, or people on blood thinners.
And what are those creeping symptoms again?
Your notes list them well. Headache is common, often worsening. Confusion, drowsiness, maybe nausea or vomiting. Focal signs might develop, like weakness down one side, hemiparesis or difficulty speaking, dysphagia. Sometimes personality changes are noticed by family.
So, acute, often dramatic, chronic, often subtle and progressive. What about the examination itself? What are you focusing on?
Your notes guide you well here. Start with the basics for any altered consciousness or head injury. Assess their GCS, Glasgow Coma Scale. Check vital signs really carefully, looking for Cushing's triad or reflex. A rising blood pressure and a falling heart rate, which are late, ominous signs of very high ICP.
And the neuro exam.
A full neurological exam is essential. Check their pupils. Are they equal? Are they reacting to light? A dilated fixed pupil on one side can be a sign of the brain being pushed across. Fundoscopy to look for papilledema swelling of the optic disc indicates raised ICP, though it's often a later sign, maybe more in chronic cases. And obviously, look for any focal weakness, sensory changes, or reflex abnormalities.
Anything else specific from the notes?
Yeah, always look for external signs of head trauma, but also check for other injuries elsewhere. In babies, definitely check the fontanelles. Are they tense or bulging? That suggests raised ICP. And consider NAI signs. Also, look for clues to underlying issues like excessive bruising, suggesting a bleeding disorder, or maybe signs of meningitis like neck stiffness if that's on your differential list. Just remember, the exact signs depend massively on where the bleed is, how big it is, and how fast it developed.
That paints a really clear picture. Okay, you suspect it clinically. How do you confirm it? Investigations.
Right. The absolute key test, the gold standard, as your notes make crystal clear, is an urgent CT scan of the head. Non-contrast CT usually.
And what does that show again?
For acute SDH, you're looking for that classic high-density, bright white crescent shape draped over the brain surface. For chronic SDH, it's also crescent-shaped, but it's hypodense dark because the blood's older. Sometimes you get mixed density if there's been recent bleeding into an old collection.
Got it. CT is king. What about blood tests?
Essential alongside the scan. Your notes list the key ones. FBC, full blood count, to check hemoglobin and platelets. UNEs, urea and electrolytes, and LFTs, liver function tests, give a baseline and can hint at other causes of confusion. Crucially, you need a coagulation screen INR, APTT, to check for any bleeding tendency, especially vital if they're on anticoagulants or you suspect liver disease. And if surgery looks likely, a group and save or cross-match is needed.
Any other imaging points?
Your notes mention that urgent imaging is definitely needed if someone has impaired consciousness, new focal neurology, or signs suggesting raised ICP. While non-contrast CT is usually the first and often only imaging needed, sometimes for subacute bleeds or complex cases, a CT with contrast or an MRI might give more information. And importantly, in major trauma, don't forget C-spine imaging and looking for other injuries.
Okay, CT and bloods are the core. Now, the crunch, management. How do we treat this?
Well, for severe acute cases, your notes rightly start with the emergency ABCDE approach. This is major trauma management. Airway first, breathing, circulation, disability, neuroassessment, exposure.
Stabilize, stabilize, stabilize.
Exactly. That means resuscitation, maybe intubation and ventilation if their GCS is low, close monitoring of vital signs. In severe cases needing intensive care, often an ICP monitor is placed to guide treatment.
And who makes the decisions?
Neurosurgery. Your notes stress this. Neurosurgical consultation is crucial for all cases, acute or chronic, big or small. They need to be involved early to guide the management plan.
Okay, let's talk surgery. When and what type?
For an acute SDH that's causing significant symptoms or math effect on the CT, the usual approach mentioned is an emergency trauma craniotomy. That means opening the skull, removing the plot, finding and stopping the bleeding source if possible. If there's massive brain swelling, sometimes a more drastic decompression is needed, but that's usually for the underlying injury.
And for chronic?
For chronic SDH, if it needs draining, it's often done via burr holes. Smaller holes drilled in the skull allow the liquefied hematoma to be washed out. Your notes make a good point that placing a drain into the subdural space afterwards for a day or two can help reduce the chance of it coming back.
Is surgery always needed? What about non-surgical options?
No, not always. As your notes say, small acute SDHs that aren't causing symptoms, maybe found by chance, can sometimes be managed just by watching the patient closely, with repeat scans. Some chronic SDHs, too, if they're small and the symptoms are minimal, might be observed. Your notes mentioned using steroids sometimes for chronic cases to reduce brain swelling, though the evidence behind that can be debated.
And just general supportive care.
Absolutely essential. Good pain relief, anti-sickness meds if needed, keeping them hydrated with IV fluids. And if that ICP is high and surgery isn't immediate, medical treatments like hypertonic saline or mannitol can be used to try and bring the pressure down temporarily, as your notes mentioned.
And just circling back to severe trauma.
Yeah, key points there.
Yeah.
Always protect the C-spine until it's cleared. Manage the ABCs aggressively. Get that CT head scan done urgently once they're stable enough. And make sure they get to a neurosurgical center quickly if needed.
So, summing up management from your notes, watch the small, stable ones, operate on the symptomatic or large ones, and provide really strong supportive care, including managing ICP.
That's a pretty good summary of the approach, yeah.
This definitely sounds like a serious condition. What's the outlook? The prognosis?
Yeah, your notes don't sugarcoat it, especially for acute SDH linked to significant brain injury. The mortality rates mentioned are sobering, ranging from 30% up to potentially 80%.
That's incredibly high. What makes the difference?
Outcomes are generally better in younger patients, but it really depends on the initial cause. How bad was the underlying trauma? And the extent of the brain injury itself, not just the SDH. Unfortunately, your notes state that overall, fewer than a third of patients end up with what's considered a good outcome.
Are there ways we can try and prevent these happening?
Your notes list some practical prevention strategies. For people on warfarin, careful monitoring to avoid over-anticoagulation is key. Fall prevention is huge, especially for older adults, particularly if they're also on blood thinners. And tackling alcohol dependency can reduce both the risk of injury and the factors that make bleeding worse.
Makes sense. Finally, even for those who survive, what are the potential long-term problems or complications?
Your notes cover a range of potential issues. Lasting neurological problems, weakness, speech issues, cognitive difficulties are common because of that initial brain pressure or injury. There's a definite risk of the SDH coming back, particularly the chronic ones. Post-traumatic epilepsy or seizures can develop down the line. Infections are always a risk after surgery wound infections, or more seriously, infection in the subdural space itself, empyema or meningitis. And cerebral edema, brain swelling, can persist or recur.
And the really severe end of complications?
Yeah, the notes list the worst outcomes. Death, often from brain herniation when the pressure gets too high. Persistently raised ICP, seizures that are hard to control, permanent severe neurological or cognitive impairment, and sadly, some patients may end up in a coma or persistent vegetative state.
Wow. Okay, that's been a really thorough walkthrough of a complex topic guided by your excellent notes. We've covered the definition, the anatomy, the causes, the risks, the pathophysiology, those crucial differentials, the epidemiology, how it lists clinically, investigations, management, prognosis, and complications.
Yeah, and breaking it down like you did in your notes, section by section, is honestly the best way to get your head around something like this. It makes the connections clear how the cause leads to the presentation, which guides the investigation and treatment.
Absolutely. And thinking about those key takeaways, like the lucid interval in acute cases reminding us to be vigilant, or that gradual decline in a vulnerable older person, possibly signaling a chronic SDH, those are the clinical insights that stick with you. It really highlights needing that high index of suspicion.
Definitely. Recognizing those patterns, knowing the risk factors, that's often key to catching it early.
Well, thank you again so much for sharing your notes and letting us work through them together. We genuinely hope this deep dive has been helpful for your revision or just for understanding SDH better. And hey, if you are studying, especially for the MSRA, don't forget to check out pastthemsra.com and also freemsra.com. Lots of great resources there.
Yeah, definitely worth a look to supplement notes like these.
Okay, that's it for this deep dive. Thanks for joining us, and we'll catch you on the next one.